we're going to be assessing the temporomandibular apparatus. We'll start with a range of motion, and we'll just proceed from there. We'll take that into some of the mobilization and manipulative techniques that can be applied to the TMJ as well. Let me just talk a little bit about the TMJ apparatus and some of the highlights of things you should really know when you're assessing and trying to manage problems with this area. The temporomandibular joint is unique in that it's lined by fibrocartilage. It contains an intra-articular disc which divides it into two parts, an upper joint and a lower joint. As I'm talking now, most of the movement is taking place along the x-axis in the lower joint. If I open my mouth wide or yawn, it will translate forward along the z-axis, coming forward a little bit, and that's what allows me to get my mouth all the way open. The space behind the mandibular condyle is called the retrodiscal space. It's highly vascular, it's highly innervated, and it nourishes the joint. When you bite down, it pushes the condyle backwards into this space, which is on the temporal bone. The mandibular fossa is on the temporal bone. So just during normal talking, eating, the joint is always massaged and nourished. Of course, if you bite down excessively, it would be like you're pounding this area, and the retrodiscal tissue can actually become inflamed, and that could be part of a patient's issue as well. The other thing to remember when diagnosing, assessing, managing these problems is sometimes it does involve it often could involve the dentition. It can involve their bite. So you have to recognize that we're not dental professionals, but recognize that there may be some issues that would be better addressed by the dentist, especially if the patient bruxes, which is them grinding their teeth at night. You might notice this as the teeth looking excessively worn, and by all means, it's a good opportunity to network with dental professionals in your community for patients who have this issue. I will also say that I really enjoy managing these cases because they're very rewarding. These patients are very appreciative of any help you can give them. They're often at their last straw when they come to you, and it can really make quality of life miserable. This is you need this joint to eat, enjoy food, and you need it to communicate. Just during socially, you need your jaw not to hurt. So with that as an introduction, let's look at some of the basic things you want to check. We're going to look at range of motion, and while you're looking at range of motion, you're going to observe what's called the mandibular gait. This is what the jaw does from full closure to full opening. It should basically track in the midline. You've got symmetrical muscles opening and closing the mouth. Gravity does most of the heavy work on opening, but it should track in the midline, and there should be adequate range of motion. For most patients, it's 2.5 to 3 of their own fingers. So you have them put their hand like this, and I'm going to bend down, and I hope the camera can still see this so that I can see this, right? And I'm just going to have you just show me your smile a little bit, just like your lips. No, just close your mouth and just smile a little bit so I can see your teeth. Now open and close. You can put that down for now, just there. Open and close. And you're looking for any deviation, either on opening or closing, as they open and close their mouth. And you can use the central incisors as a guide. Now go ahead and give me that opening and see what you do when you try and get those 2.5 right here, right there. And I would say that's 2.5, right? So it could be a little limited. We won't necessarily know until we perhaps intervene and do some therapeutic interventions. But he had about 2.5 of his own fingers, and the mandibular gait was pretty symmetrical, right? He tracked in the midline. Generally, if you have a restriction in the left or right TMJ, when the patient opens their mouth, you may see deviation to that side. deviation to the side of the restriction. But it can be complicated too, because you've got the temporalis, you've got the masseter, you've got the pterygoids all acting, and any imbalances in those muscles can cause opening and closing. Sometimes there'll be a click as well. So the click could represent a disrelationship between the condyle. So here's the condyle, it sits on the disc, and they move together during opening and closing. So if there's if there's been trauma, if there's any kind of disrelationship there, it could manifest itself as a click, painful or not. And I'll come back to that especially when we do the manipulative procedures. Okay? So in addition to looking at the gait, opening and closing, we also want to measure protrusion and retrusion and laterotrusion. So protrusion and retrusion are when the patient attempts to put their bottom teeth in front of their top teeth. So go ahead and try and stick your jaw forward, but let me see your teeth a little bit and go ahead and do. There you go. And that's maybe about 1/4 of an inch. Now come back and relax. And now try and go backwards. So you're trying to bring your bottom teeth behind your top teeth. So come out again, protrude, and now retrude. There you go. And protrude again, and retrude. Is that as best as you can retrude? Bring it back. Okay, so retrusion is usually the weaker movement. The masseter, which is one of the strongest muscles in the body for its size, assists in protrusion, and of course it dominates the movement. So most of us have good protrusion and not enough retrusion. So when we rehab down the road, we might want to try and develop that retrusion ability. All right? And then laterotrusion is a little bit easier to measure. So again, you have the patient kind of smile and open a little bit, just a little, no, less than that, a little more than that. And now deviate your jaw to your left and deviate your jaw to your right. And try and get yourself in a position so you can observe this. So deviate left, back to the center, deviate right. And back to the center, and deviate left again, the other left, and back to the center. And now relax, just relax. Open a little bit, slowly deviate left, back to the center, and slowly deviate right. And back to the center. So there's a little better right laterotrusion than left laterotrusion in this instance. Just slight, all right? And again, that can represent either a restriction on one side compared to the other, or an imbalance in the musculature. And it's good to measure these, even if we're not going to get numbers for them, because then we can look at it qualitatively and see how our treatment interventions have affected it, have they changed it. So once we've measured laterotrusion and protrusion and retrusion and opening and closing, and we looked at the mandibular gait, we also want to palpate the lateral pole of the condyles. So one thing to keep in mind is where is the joint. So if you look at the little bump, turn your head a little bit, this little bump right there is called the tragus of the ear. And right in front of it, above the zygoma, right? So there's the zygoma. Below the, what am I saying? Right below the zygoma is the lateral pole of the condyle, right? So here's the cheekbone. I'm right in front of the tragus. If you have your patient open and close their mouth, you'll feel the lateral condyle pop into your digits and move forward, all right? So with some light palpation, all right, have them open and close their mouth. You'll feel the condyles move forward, and your digits will kind of fall into that retrodiscal space as you perform that. Feel for symmetry. You know, does one side move further? Is it one side like pop open or click open compared to the other? And also note any tenderness in this area. So do you feel any tenderness in there? Okay. There should never be any tenderness over the lateral poles. If there is tenderness from palpation that you think wouldn't normally be tender, then you want to consider that there could be an issue, all right? Also, palpate the masseters, right? The masseters are always tender, right? The masseters will harbor trigger points. If you think about it, they're always on. Some patients can't even turn them on at, when they're sleeping. Feel those? Little tenderness. You'll always find triggers in the masseter, and the masseter should always be more tender than the lateral poles of the condyle. That's kind of like your general rule. All right. The other thing you can do, I'm going to have you straddle the table so you're facing this way. Yep. And the camera will be able to see this. Sit up nice and tall. So go ahead and open and close your mouth. And what you're looking for is for the occiput to move. In patients who have TMJ issues, sometimes you'll see them try to attain full opening. Now, you don't have that, right? We're not seeing this here. But sometimes you'll see the occiput kind of nod back a little bit because they're using extension of their skull in order to get full opening, because the TMJ won't open fully. So sometimes you'll see this after whiplash injuries. So you can come and face forward again. So again, that's just a mouth opening test. Just look for a little bit of extension of the occiput when they try and open their mouth fully. All right. So now we're ready to palpate for joint play. All right. So joint play of the TMJs is accomplished by donning gloves, putting gloves on, and basically performing 3 movements. So what I'm showing you now, and some of the things I've been talking about, is based on the work of some famous chiropractors from our past. Dr. Steigerwalt is a chiropractor, DC. He's done a lot of work on this, and he's written pretty profusely on it, especially in the whiplash literature. And the other doctor that comes to mind that I want to give credit to is Dr. Darrell Curl. I think it's C-U-R-L. He's a DDS-DC, dentist, chiropractor. And that's where I first came across a lot of this stuff and started to incorporate it into my management of these patients. So I'm going to see if this will lower down a little bit. I think it might have been all the way down. Oh, there we go. Okay, good. So what I'm going to demonstrate is joint play, diagnostic joint play, but this also becomes therapeutic as you perform it, right? So initially when you're doing it, you're doing it to see what you feel, but if you continue to perform it, it actually becomes therapeutic because you're improving the play. So there's 3 basic motions. I'm going to demonstrate it on one side today, but of course you would do this on both sides, right? So sit back a little bit for me, right? And I'm going to have you turn to your left, all right? So I'm going to position myself behind my patient so that I can very firmly hold on to their head, right? Because I want to isolate the maxilla, right? So I do that by holding the forehead and then by holding them into my chest. Now the other thing that I should have mentioned, you want to make sure that they have good dentition. You don't want to have anyone with loose teeth or issues with their teeth because you're going to be putting some pressure on the teeth. So do you have any issues that I should know about? So young healthy mouth, good hygiene, no issues. There could be issues and you may want to avoid this type of an assessment and treatment. So the first movement is a play of just downward movement, right? A little bit of down play. So what I'm going to do is I'm going to put my thumb on the bottom row of teeth, as far back as it'll go. Only my thumb's going to be inside. The rest of my hand will be wrapped around the mandible, and I'm going to grab the mandible in such a way that I can have my patient open their mouth, and I'm just going to kind of see if I can initiate some of this play. I'm going to do it in short bursts because I don't, he's going to want to swallow, and I don't want to necessarily create a problem for my patient. So I'll do it in short bursts to allow them time to regroup. So here we go. Let's open your mouth. And there's the first movement. I position my hand and I ask them to try and relax, and I'm pulling down towards the floor. You can see my hand position there. And I'll take my hand out. So that's the first movement. Just straight down. It's kind of like how you might mobilize a shoulder or a hip, except we're applying it to the TMJ, right? So again, my thumb's on top and it's just pushing down while I hold on to the outside. Let's do another round. Let's keep your mouth open a little bit more. And relax it now, and I'll do this in different positions of opening. And I'm just pushing down. And then I'll relax and take it out. So a little bit open, medium open, wide open. And again, the more you do it, the more therapeutic it becomes. Open up again, halfway, just let it relax, and push down like that. Okay. So that's the first movement. The next movement is going to be a combination of what I just did, but I'm also going to pull the jaw forward. Right? So my outside fingers on, especially behind the ramus, is going to be doing a little bit more work. All right? So it's going to look like this. And again, remember, I'm holding firmly here so that the maxilla and the rest of the skull doesn't move. So relax it. So I'm pulling forward and pushing down at the same time. Short bursts. Take my hand out. All right? We'll do it in different positionings of opening again. So again, this is down and forward. The first one was just down. All right? This is down and forward. So these fingers behind the jaw are doing a little bit more work. So open all the way. Now relax it and let it go loose. So again, initially starts off diagnostic. What does it feel like? And the more your patient gets comfortable with it and used to it, the more therapeutic it becomes because they'll be able to relax. So we'll do one more like that. Open, let it go loose, and down and forward, down and forward, down and forward, down and forward. Okay, so that's movement number 2. Movement number 3 is going to be to when your jaw goes side to side, there's actually a little play of the condyle away from the temporal fossa, right? So we're going to accomplish that. The first two, my thumb was on top of the teeth. Now my thumb's going to slide inside, right? It's going to be inside the row of teeth, and I'm going to push outward towards the camera, right? I'm going to be pushing away. And the rest of my hand is going to be kind of countering the jaw in the front to kind of help me do that. So let's open up halfway. I'll slide in, come inside, and there's the motion right there. Just did 3 little bursts. So I'm doing this. Just like that. Open again, come inside. You're up against their tongue, so make sure you don't get in there too far. You don't want the patient to start to gag on you. And again, I usually do just 2 or 3 bursts and then give them a break. 2 or 3 bursts and give them a break. We'll do one more for the camera. So open up wide, get your hand in place, come inside, and just gently try and push it away from you with your hands working on the outside. All right? Okay, we'll keep this rolling for another few minutes. I'm going to show you one more thing while I have the glove on, and that's going to be a little massage of the lateral pterygoid. Just a part of it you can reach. And what I'll do is I don't want my back to get in the way. Normally I'd stand in front of the patient, but I think if I'm here, the camera will be able to see it. I'm going to take this finger, my index finger, and I'm going to place it outside the top row of teeth towards the very back, all right? Towards like those pterygoid plates on the, I don't know if that's the exact name, but there are these plates on the skull that the pterygoid's attached to, and I'm going to try and get as far back as I can. Now, let me say this is a very sensitive area. So you want to be delicate. You want to, consider the patient's sensitivity, and watch their facial expression. Tell them it's going to be uncomfortable, and take that into consideration. You don't want to be too aggressive with this. Also, if you have them deviate their jaw to that side, it'll give you a little bit more space. So in this case, I'm going to be doing your right side. You're going to deviate to the right, the other way. There you go. Lateral retrusion to the right. All right, so here's what it looks like. Can the camera still see this okay? Okay, so open up wide. I go inside the cheek. I'm up along the teeth. I go all the way back, deviate to the right. There you go, stay to the right. The other way. There you go. And then I can get in there and work it a little bit. You okay? Mm-hmm. So I'm just massaging it. I'm just kind of going back and forth. All right? So again, when they deviate, you'll get more room. If they deviate to the wrong side, you'll know, just tell them to do the opposite, right? It's very common with patients. Even chiropractic students can mix it up, right? It's not uncommon. Let's do one more. So open up, So kind of get inside the cheek, come up along the teeth. Yep, this time you got it, deviating, and I'm up in there and I'm working it. And that's it. And of course, you would do all these things on both sides. All right. Even if the complaint was primarily on one side, all these techniques would be applicable to both sides. The other thing that I would consider that I'm not going to show in this video is doing some connective tissue work on the other muscles of mastication. So that would be like ConnectX or instrument-assisted techniques on the masseter, on the temporalis, NIMO, ART. All those types of techniques can be brought to bear on the apparatus of the TMJ. I'll look at dentition. Stress is a factor when it comes to TMJ, especially in patients who Brox. So there may, it's a multi-disciplinary approach works best. And the other thing with the TMJ is less is more. You don't want to do too much. You want to kind of just get the joint moving better and then just let nature take over. It's very recuperative on its own. Fibrocartilage, it will regenerate itself. It will reshape itself to function properly. And there's probably some more, but it's not coming to mind at this very moment, so perhaps we'll do another video on assessment down the road. But the next demonstration I'm going to do is the manipulative procedure, which in a moment we'll break and we'll start over again. But so when I say manipulative, I'm talking about an HVLA. So HVLA is the last thing you do, right? If you're getting somewhere with what I've just shown you, just stick with that, right? You don't need to do the manipulative procedures if this is working. I would never jump right to the manipulative procedure first. I would work my way up to the manipulative procedures. So let's cut it out right there, and then we'll start over with a manipulative setup.